Did you know that male testosterone levels drop 3% every year starting at the age of 40? I'm Dr. Mary Pardee. I'm joined today with Dr. Sarah Williams. We're going to be talking everything testosterone, testosterone replacement therapy, what does testosterone do for the male body, and all things in between. Welcome, Dr.
Yes.
Williams.
Thank you. Thank you for having me. I'm excited to talk about this.
Same. I'm excited with all the research that you've done that I'm going to gain some knowledge from this interview. So let's dive in.
Let's do it.
We wanted to do this interview specifically about men. So we're covering male testosterone information, education, and testosterone replacement therapy when it's appropriate, when it's not, and just testosterone 101, all the things. But let's just start with the real basics. Like, what is testosterone? Why is it important?
Yep. So testosterone is one of our sex hormones. It's a primary male sex hormone. So we really see it being responsible, of course, when you're younger, when you are growing and maturing, developing. So it helps develop the prostate and your testes, but it's also important for the other characteristics like body hair and gaining muscle mass, sex drive, energy. So it plays a lot of really important roles throughout our life.
Yeah. And I will put like a caveat in here where women actually have more testosterone circulating than they do estrogen. So it's extremely important to both sexes, but we want to cover men specifically today. And we have a whole nother video for women.
Absolutely.
How common is low testosterone? I know it's something that you treat a lot of, but in general.
Yeah, so it's something that, like you said, it is something that we see decline in men as they age, regardless of symptoms. And it's estimated to be about 1 to 3% per year starting at age 40. And there was another study that was done that showed that men in their 60s, about 20% of them had low T, and then that increased to 50% when men were in their 80s. So it is pretty significant and prevalent in our society.
Yeah, especially it sounds like after the age of 40, really after 50, we see higher amounts of people being diagnosed with it. What would be some of the signs, symptoms that a man may notice if his testosterone is low?
Some of the biggest ones to look out for are lower sex drive, low libido, erectile dysfunction, or even noticing like decreased morning erections is something I always ask my patients about. Also, just having a hard time gaining weight or finding that you're losing muscle or just not as strong as you used to be is another big sign. Overall, like lower energy, maybe a little depressed. Those are some really common ones.
Are morning erections normal?
Yes, it's a really good sign of vitality.
Yeah, absolutely. This is also a really sensitive subject for men to talk about, I would imagine. You work with a lot.
100%.
How is this something that usually people are coming to you wanting to address, or does it kind of come out where they're saying everything's fine, and then, in the intake you uncover some things, or how does that usually unfold in a visit?
It's honestly usually something that people are already coming to me about. So even though it's a sensitive topic, it's bothering them enough that they want to be open about it and see what we can actually do about it.
Yeah, yeah. We often say in medicine that men are less likely to seek help, but I would say there's like one exception or a couple, but this is one of them. When sex drive is affected or erections are
Mhm.
affected or any of that, I think they're a little bit quicker to make an appointment.
I agree. Well, it is just such an important aspect of our lives. And it's really important that we have good, healthy sex lives. So
Yeah.
I'm glad that it's something that people are becoming more aware of and are willing to see doctors about.
Yeah, absolutely. Let's talk a little bit about gynecomastia. Why does that happen in men? Does it always happen with low testosterone?
So it's not always commonly seen with low testosterone specifically, but it is something that can happen when we have too much estrogen. So testosterone aromatizes to estrogen. So sometimes if there's some dysregulation there, we can have gynecomastia, which is essentially like too much fat tissue growth on our breasts.
Yeah, so males having more breast tissue than would be normal.
Mhm.
And what are the causes of low testosterone?
Yeah, so there's a lot of them. I like to divide them into two main sections. So we have primary, which is where we actually have the testes that aren't working as they should. And so there's some bigger ones like you can be born with a genetic disease that affects this. There's other things like physical trauma or like radiation, things like that, that will affect your actual testicular function and ability to make testosterone. And then there's secondary, which is what we call more acquired, which is often an issue with our brains signaling to our testes to make the testosterone. And these are usually things like type 2 diabetes is a really big one that we see low testosterone be common in. Other things like hypothyroidism, hyprolactin, adrenal conditions like Cushing's, like those are some really common ones that can cause more of that picture.
Yeah, and then the other one we were talking about was hemochromatosis, which I've seen a few times,
Mhm.
um, especially in young people. So in young people, we're always looking at potential secondary causes, right? Because we're assuming that the testicles should be functioning properly, even, in the younger years. So looking at, is there
Exactly.
another source of this coming in?
Yep, exactly.
And then
Another one, not to interrupt you, but I just thought of this and I think it's really important in this day and age. But another one is like, certain medications, of course, like steroids and opioids.
and what happens when we age?
Yes. So this is what we call late onset hypogonadism, which we actually see as a mix of both of those primary and secondary characteristics we just talked about. So there's a dysfunction on both ends. The testes aren't working as well, but the brain signaling isn't working as well either. So this is a normal thing that we do see with age. We see that testosterone and some of our other markers will all decline with age. Seems like regardless, but then there's other things that can kind of compound on top of that that will further worsen that. Like obesity is another really big one. For instance, one study showed that 40% of obese males had low testosterone.
Wow, it's really significant.
Yeah.
And obesity is super common. So definitely something that we're screening for.
Mhm.
You did a really good job explaining this, and it can be a super complicated thing to understand, primary versus secondary. So I just wanted to go through it again. Primary, what hormones are high and which hormone is low, so people can understand, and where are those kind of coming from?
Yeah. So primary is when we have your LH and FSH, which are the brain hormones signaling to your testes to make the testosterone. So if those are high, that means that you have primary versus secondary is when we see that that signaling is working fine. FSH and LH are normal, but we see that testosterone is still lower than it should be.
Yeah, so primary, you have high FSH, LH that are signaling to the testicles that aren't responding. So you have to send more and more FH and LH out because you're trying to get those testicles to respond, even though they're not. And then secondary, everything is pretty much normal to low. So you have LH, FSH that is being sent out, but not at a high level. And then your testosterone is still going to be on the lower side too.
Exactly.
Um, Great. And did we talk about conditions that we see low testosterone in yet? I think brief.
But yeah, I talked about diabetes is definitely a really common one. But other things too, just like chronic illnesses as we age, like kidney dysfunction, liver disease, lung disease, HIV, like those will absolutely impact our testosterone as well. And then another one too is actually sleep apnea is always something that we want to be screening for as a cause for low testosterone.
Yeah. Even in some of our patients with inflammatory bowel disease, I'll screen for testosterone because
Mm,
been really sick for a long period of time. Sometimes that can show up in your endocrine markers as well. Um,
absolutely.
when we talk about low testosterone, we always want to talk about health consequences. Is there any age related, as we're aging, is there any actual consequences to our health with having low testosterone levels?
This is a really fascinating topic that I really dived into for this talk. And it's actually pretty inconclusive of how much of an impact it actually has on us. So a lot of people might have low testosterone but not even have symptoms is something that we've actually seen. Like one study, which is really interesting, looked at like a little over 3,000 men who were aged between 40 and 79. And they found that men who had low testosterone, in addition to three symptoms, was only 2.1% of that population, which is really low. But that being said, I mean, I really see the impact that it has on my patients, and we do see that some of the signs of aging are probably linked to that decline in testosterone. So, having the decreased libido, decreased muscle mass, and then other ways it shows up that we haven't really touched on yet too is having lower bone mineral density. So really predisposing you to osteoporosis too.
Yeah, which is super important. Dr. Shaler and I just touched on that with the women's HRT video that we
Mm,
did, but just as important in men in terms of you don't want to fracture a hip, especially the older you get, the mortality risk skyrockets.
yeah.
It's interesting that that study decided to do three symptoms. So people had three sexual symptoms and low total and low free. It just feels like a really high bar
Yeah.
to hit that endpoint where it's like, what if you had like one or two symptoms? That might be enough to say like, okay, I don't want those one or two symptoms anymore.
I totally agree. Yeah, completely. So I do obviously think that there are consequences to the testosterone declining, but I think it's like looking at the person as a whole and seeing like, okay, do they have low testosterone in addition to symptoms, and how much is it impacting their quality of life?
Yeah, yeah. And if we go back to the symptoms of low testosterone, even if we're not talking about, okay, it's going to increase your risk of X chronic disease that could lead to mortality, um, just reiterate some of the symptoms because those are sometimes enough to want to treat them, even if it's not going to cause a shortened lifespan.
Yeah, absolutely. More energy, better mood, more muscle mass, better sex drive, erections. Those are, yeah, things that it would definitely be helpful with.
Most men want those things.
Yes,
Okay, so
absolutely.
somebody comes into your office, a man, and we can take a case example here, but whether it's a 35-year-old man or it's a 55-year-old man, they come in. What are you doing for testing? And run us through kind of what that intake looks like around it.
Yeah, absolutely. So, of course, going through all the symptoms, seeing what they have, how long they've been having them, seeing if there's any other, predisposing factors or triggers. But as far as testing goes, one of the main things we want to test, of course, is total testosterone. And this is really important to test at the 8 to 10 a.m. window in the morning and fasted for us to get the most accurate picture. So I see a lot of people come in, they're like, oh, well, my testosterone was checked at 3 p.m. and it's low. And then we recheck it at the right time and it's significantly improved. So I really want to stress the importance of this because I see it happen often. But it's really important to test in the morning, fasting also because we have seen that food and sugar intake does actually lower testosterone too. So want to be testing in the morning. Ideally, the gold standard is testing on two separate occasions to make sure that we're getting the most accurate picture and just wasn't like a false low. So that's definitely one that I want to make sure that we are looking at. And then free testosterone is another really important piece because that is what is actually active and circulating and what we can actually use. So free testosterone really only represents about 2 to 3% of the total. The rest of the total is bound to either sex hormone binding globulin or SHBG for short or albumin. And so really it's only this 2 to 3% that is actually free and active. So we really want to look at that to get the full picture as well. And this one's really interesting because research has shown that our free testosterone falls faster than our total testosterone with age as well. So it's a good one to check for that reason alone.
Yeah, really interesting. And then people are always asking, how can I increase my free testosterone? My total is fine, but like SHBG, how do I decrease that or it's higher than normal? And when we're looking at testosterone levels, are you using just standard lab ranges or how do you kind of assess somebody when they come in?
Great question. So the ranges vary depending on which lab, which study. So they're kind of all over the place and they honestly even keep changing. I think a great reference is to LabCorp's lab range. They actually lowered it in 2017 to a much lower range. So it was 348 to 1197, which is a huge range in and of itself. And then they lowered it to 264 to 916. And this was based off of a study that they did on healthy, not obese males. But essentially, I think it's a really important piece to mention because just because the overall average is lowering doesn't mean that that's necessarily what's healthy or optimal. And so I really like males in general to typically be above 600. Obviously, this varies with age to some extent, but that is what I typically see males feel their best at.
Yeah. Okay. I'm going to give you a little case example. You got a 37-year-old guy comes into your office and he's just seeing you for overall wellness, longevity, preventative medicine, no symptoms at all. You run his panels and testosterone comes back at like 520, let's say. What would that conversation be like? Free testosterone looks okay. What would that conversation look like that you would have with him?
Yeah, I mean, I really would base it off of symptoms. If he's overall feeling really good and doesn't have any symptoms, I would say, yeah, ideally, I would like this to be a little bit higher for your age. You're in your 30s, and we want to be proactive as you age as well. And I would really start with the lifestyle piece, like strength training, especially, is a really great way to boost your testosterone. Sleep, like I mentioned, like I would really just make sure that we're working on those things first. And then I think that we would see his testosterone would increase anyways.
Yeah. Yeah, not jumping to Clomid tomorrow, I guess is my point.
Yeah, no, I definitely wouldn't jump to anything, any type of replacement like that.
Yeah. Yeah. Symptoms are such a big part of it. It's like we want to see the, optimal ranges to some extent, but the symptoms matter so much as well.
Yeah, I say
Anything
that
else,
so often to my patients.
anything else to comment around the free testosterone, or did we mostly get what we are looking for around that?
Yeah, I think the biggest thing was that we want that to be about 2 to 3% of the total testosterone. So that's a really important thing to look at. I think that was mostly it with that one.
Yeah, and this is the free testosterone, to reiterate what you were saying, is the one that's able to exert its effects on the cells because so much of it is bound up by the SHB and albumin, which is why we look at that one. And then any other labs that you're looking at around this, if people come back abnormal, some things that you may use to follow up with that.
Absolutely. I always like to look at the full hormone picture. So I'm usually looking at DHT, which is dihydrotestosterone, which is what testosterone gets converted into. We want to make sure that we're staying in a good range for that, especially if we start replacement too, because that's the one that has been associated with more like male pattern baldness and more acne, some potential side effects if we're pushing that or if that's already too high to start. And then estrogen is another important one to look at, especially we talked about like gynecomastia. We want to make sure that one's in check. Of course, FSH, LH to try to figure out what the cause of it is. And then a really important one, especially if we are considering testosterone replacement, is looking at your blood count. We want to make sure that red blood cells, hemoglobin hematocrit, are in a good healthy range and staying in range if we start replacement. And then last but not least is the prostate specific antigen or PSA, which is going to look at potential inflammation in the prostate. We want to make sure that that is in a good healthy range too.
Yeah, I love that. And then the other thing that came to mind was the estradiol. I had this recently where I've had a couple of cases over the last couple of years where men come to me already on anastrozole, and
Mm.
estradiol level, I remember one of them was at like 10, if that, like it was like really, really low. And the conversation, I'd like to hear what you say, but the conversation I had with him is like, that is way too low for estradiol. Estradiol is so important in men as it is for women. We don't want it to be high if you're aromatizing a ton when you're on testosterone replacement therapy. But it has so many benefits for our brain, for our bones in both sexes. And so I really don't like to
Mhm.
see it at the bottom end of range. I want to see it in a healthy range, around like the 25 to 30 range. What about
Mhm.
you?
Yeah, I totally agree with you. So it doesn't sound like that patient needed to be on anastrozole, or at least as much as he was taking. I don't like it to be that low either.
Yeah. Okay, so to replace or not to replace. So with testosterone replacement
That is the question.
therapy, yeah, that is the question. Testosterone replacement therapy, are there benefits that men see when they decide to replace?
Yeah, so this is another interesting one. In the past, this was seen pretty inconsistent with the research. There wasn't evidence to really suggest that replacing was actually that helpful. So they started implementing some more trials and studies. So a really important one was done in 2003. It was called the testosterone trials. It was placebo controlled over the span of 1 year. The men were over 65 years old, had low testosterone and symptoms. And so, as a whole, they looked at a lot of different symptoms and how things changed and improved. And the main conclusions that this trial came to was that it is helpful for sexual function, libido. They saw improvements with mood and depression, and walking was something that they assessed for, that they saw improvements with. Sounds interesting. And then they saw improvements with iron regulation and bone mineral density were the biggest ones. They interestingly, with the measurements they used, didn't find that it was helpful for overall vitality and cognition, which was an interesting one. But yeah.
Those feel harder to measure too.
Mhm.
I mean, there's a lot of benefits that you just listed there, so it wasn't like just a
Oh,
couple of
absolutely.
that improved.
Yeah.
And then the walking, I'm wondering if the walking was like motivation related. Do you have any idea like why they thought that that improved
For which one?
for the walking?
Oh, yeah. I'm not sure. I would have to look into it further.
Yeah, yeah, I'm
Yeah,
wondering if
maybe
like
maybe
motivation
motivation
related
driven. Hmm.
yeah, interesting.
Yeah.
Um,
Yeah.
So let's just talk about, again, let's go back to one of our cases. We'll choose a 55-year-old man in this case, but he comes in, his testosterone, let's say, is 315. He has symptoms. So he has, difficulty maintaining an erection, low motivation, low libido. You decide to put him on testosterone replacement therapy. What benefits would you
Mhm.
think that he may start to feel from that? And then also, if you can walk us through, first of all, like, how are you deciding to use an injection versus a cream? Where does your brain
Mm.
go with that?
Yeah, great question. So I would expect him to see improvements, especially with the energy, his erections, sex drive, and overall like muscle strength is another big one that we do have good research with, that it does increase. And in a pretty short time frame too, like this one study showed in 10 weeks, they had, 22% increase in their strength. So those would be things that I would expect him to feel pretty quickly. And the two main types of replacement that I utilize are the topical gels or intramuscular injections. I personally lean more toward injections for most patients. I find that it is more effective and people are able to be more compliant. I find that sometimes people have a hard time absorbing the topical gels, and it's a daily application too. And there's just more things that you have to keep in mind. And, even hair, like having too much hair can affect absorption. So I don't find it's as consistent with, dosing and getting your levels to an optimal range. But it's all about, having that conversation with the patient, discussing the options and seeing with what they want to start with and what they feel the most benefit with.
Yeah, yeah. There's some people that are just going to refuse to inject anything. So it's a nice
Yeah.
option to have there. And then the other thing is like if they have a partner or children, you worry about the cream.
Yeah. The transference. Hmm.
Can you just talk a little bit about what we're talking about so that people understand?
Yeah, so when you're using any hormone cream or a gel for that matter, when you're applying it, of course, you're trying to rub it in as much as possible. But if you are, soon after touching your pet or your partner, your kid, and it's rubbing off, you're sweating at all, it can really affect their hormone levels and increase them as well. So that's something you always want to be really, really mindful of when you're doing any hormone topical application.
Yeah, absolutely. Um, Potential side effects of testosterone. I think a common one we get, especially with women, if we're putting them, but we're just talking about men today. But it's like, am I going to get roid rage? Am I going to be angry? Like, am I going to start to have like acne or whatever? Like, what is there merit to those? Do you often see them? Tell us about the actual potential side effects.
Yeah, I often don't see really like the roid rage or irritation. That's not a common one that we see. Acne can definitely be one that we see. Sometimes some difficulty urination or having like some enlarged breasts or sensitivity or even nipple sensitivity could be possible. And general fluid retention is something that we can also see too. So those are some ways you might feel it if maybe the dose isn't right or you're not absorbing it properly. Another one that's always important to note, especially if we're talking about maybe replacing in a younger population, is that there can be testicular atrophy and also decreased sperm count. That's always something we want to be talking about as well, and making sure, that fertility isn't in the near future.
Yeah, yeah, that's really important. So, say you do have a 35-year-old male that comes in and his testosterone is 350 and he's tried all of the um lifting and exercise and like lifestyle and sleep, like he's got everything kind of locked in. I don't want to go into like the real treatment for men under the age of 45 right now, but would you be throwing him on TRT? And if not, why not? But what do you think about
Mhm.
that?
I would not because of its effect on sperm count. And so especially if the patient is unsure that they want to have kids or not, we really don't want to affect their sperm count that significantly. And usually, testosterone is something that people are on for an extended period of time. So it'd be something that I just wouldn't feel strongly about starting them straight on testosterone replacement. I would explore some of the other options. Like I know you mentioned Clomid before. That would be ones that we would definitely want to try first before doing the TRT.
Yeah, so having that discussion, making sure it's really um, just apparent and like has been thoroughly talked about is the effect of potential, decrease in fertility or impairments in fertility if they want to have children later on. A lot of the times it can be reversed, but I always tell people it's like I don't obviously have a guarantee either. So like there's always
Mhm.
an inherent risk with that with younger people.
Yeah,
Um,
absolutely.
and then let's just go over some risks of testosterone replacement therapy. What are the big ones that you talk to your patients about?
Yeah, I think that the common ones are, is it going to cause inflammation in the prostate and potentially be linked to BPH, which is benign prostatic hyperplasia, causing a lot of urinary symptoms. That's a common one. And then kind of hand in hand with that is prostate cancer in and of itself. And actually, like the testosterone trials looked into this, as well as some other a meta-analysis that looked at over 51 trials in the past. And essentially, both of those came to that there is no adverse effect on urinary symptoms and linked to BPH, and there is actually no increased incidence of prostate cancer on TRT. So I think that that's sometimes a little bit of a myth and a concern, and it is something worth, talking about, testing the PSA, monitoring things appropriately, but it isn't a strong concern or risk that we see at this point.
Yeah, great. That's really good news. What other things potentially?
Cardiovascular events, this is a big one. So essentially, like, is TRT linked to increased heart attacks and strokes? And this is something that actually in the more recent years, we've had some really good trials and research come out. One was done in 2015, one was actually just published last year in 2023. And essentially, especially the 2023 one was really interesting because they took men who were 45 to 80 who already had a high risk of cardiovascular disease, and they compared placebo versus testosterone replacement. And they found that over the span of a 22-month time frame, there's actually no increased adverse events in patients who received testosterone versus placebo.
Hmm. Really great, especially how recent those studies are too.
Yeah, the other one was looking at the thickness of our carotid artery and then also looking at the calcium score and found no change either with people who were on TRT.
Yeah, okay. What about sleep apnea? It's another common one we talk about.
Yeah, so this one's pretty inconclusive at this point. There are some studies showing that if we're replacing testosterone, you will cause or worsen sleep apnea potentially, but then there's some that show that you won't. So it's a little, yeah, hard to say with that one.
Don't know yet. Cholesterol, lipids, lipoproteins, any research on those?
Yeah, there is some research on this. Essentially, we see that testosterone replacement might slightly decrease cholesterol, LDL, but also your HDL, which is more of that healthy protective fat. So it can lower things a little bit, but doesn't seem very substantial.
Okay, and then erythrocytosis, what is that big scary word? And yeah, just what does it mean? But this is something we commonly are screening for in TRT, so just kind of talk about that in general.
Yeah, this is a really important one. So this is why I mentioned that we need to be checking your red blood cell count with your hemoglobin hematocrit. So essentially, erythrocytosis is high red blood cells. Essentially, I think of this as like you're thickening the blood, which does happen to some extent with testosterone replacement. And the risk of this is that it can potentially lead to blood clots or thromboembolism. And so we just want to make sure that we're routinely checking your red blood cells, hemoglobin hematocrit to make sure they're staying in a good, healthy range.
Yeah, great. And we already briefly talked about the types of testosterone replacement therapy that people have options for, men specifically, but just a general overview of like what are all the modalities, the things that people can use to increase their testosterone when it comes to prescription.
Yeah. So the topical gels and injections intramuscularly are the ones that we do. There are pellets, which people may have heard of, which is where you get actual pellets of testosterone injected in your glute muscle, and you're kind of stuck with that dosage for, about 3 to 6 months. So that's just a different way to do it. Another interesting one, the thing that's come out in the last couple of years is actually oral, like capsules of testosterone replacement. But this is really the side effects are much higher. So we've seen it causing liver inflammation and dysfunction. Also, we do see more of an increased risk for like high blood pressure, strokes, heart attacks, things like that. So I don't recommend those.
Yeah, and typical dosing in terms of not milligrams, but just frequency. If someone's going to be injecting, what does that look
Mm.
like?
Yeah, typically once a week for injecting, and then topicals would be daily.
Not too bad. Do people usually self-inject when you teach them, or someone else have it? Does, wife do it, or what do you see the most of?
I see the most of men just doing it themselves, but I do have a couple who their partner will do it for them.
The first
Great
time you
question.
inject yourself, it can be more painful because I remember the first time I injected myself, not with testosterone, but you like go so
Yeah,
slow because it's like it's so much easier to inject to somebody else, but
I
watching
agree.
somebody inject themselves the first time, you're just like, go faster, you gotta do it.
I know it is a little weird to be like, putting a needle in yourself. It's different.
It's different, but you get used to it for sure.
Yeah.
Any
Yeah.
big things we didn't touch on that you think are important for people to hear when we're talking about testosterone replacement for men over the age of 45?
I think we covered a lot of the good, important things.
Yeah, same.
And I think I would just emphasize, if you have these symptoms, look into it further. There's a lot of options, even besides replacement that we can look at. And it's really helpful to look at the whole picture, which I think is something I personally see often miss with patients. They look at just, one marker, and we're missing all these other things that can really be contributing. So it's good to look at the whole picture.
Absolutely. Great point. Awesome. Appreciate all of your time, all the research that you did, and we'll be back for another great topic in the future.
Can't wait.